Since MS is a chronic condition without a cure at this point, it's very important to understand how we think someone's MS will behave going forward. This will help us to identify treatment strategies and other ways to help keep somebody safe and living with a great quality of life. One of the things we use for this is prognostic factors. And so here we can see a list of demographic and environmental prognostic factors that include if somebody has symptom onset over the age of 40, more commonly it's a more severe or aggressive course of MS. Same thing in general, males have a more aggressive course of MS. People of non-Caucasian ethnicity, patients with low vitamin D levels, people with a history of tobacco use, current tobacco use, or exposure to tobacco smoke, all might have a more aggressive course of MS. This next slide looks at early disease activity factors, including multifocal initial presentation, so patients who have symptoms that appear in multiple parts of the body, people who do not recover completely from a relapse, so let's say that there was an optic neuritis and vision was blurred, and they only recover 50% of vision, or a leg became weak, but it's never back to full strength. Those are poor prognostic factors. Also, if some of the early symptoms that somebody experiences from relapse include loss of strength, which we call motor symptoms, issues with balance or control of movement, which we call cerebellar symptoms, early sphincter symptoms, which could be bowel or bladder control. If there is a rapid rate of relapse, somebody has a relapse, maybe they recover, and while they're being worked up or while you're waiting to change treatments, another relapse occurs. Multiple relapses within a year. That could be a poor prognostic factor as well. The last one on this slide is disease activity despite treatment or disease-modifying therapy. So when people break through multiple disease-modifying therapies, you definitely want to put them on something that is considered to be highly effective. We have another talk on MRIs where some of this is mentioned, but let's review what we look for on MRIs and what could indicate a more aggressive course of MS. People with a heavy burden of disease on the MRI brain, so multiple lesions or a high volume of lesions, just many larger lesions where much of the brain is covered with MS lesions. An excessive number of T1 black holes or T1 hypointensities on the MRI of the brain, persistent contrast-enhancing lesions, an excessive rate of brain atrophy or shrinkage, brainstem and or cerebellar lesions, brainstem and or cerebellar lesions on the MRI, or spinal cord lesions on the MRI. So it's not just, yes, I had an MRI and it showed spots, and it's definitely not how many spots did I have, which is a common question. There's all these other features that we're looking for based on the MRI and the information it provides. Another tool in our pocket is the good old-fashioned neurological examination, which consists of testing the cranial nerves, testing for strength, sensation, reflexes, walking ability, balance ability, etc. What we do is we take this information and we plug it into a ridiculous but useful scale called the EDSS, which you can see here. And this scale tells us somebody's, quote, level of disability, unquote. It is an imperfect system and scale, but it has been used forever in the world of MS. It is used in clinical trials and provides lots of useful information. It is heavily skewed or favored towards walking ability. So somebody might be able to still run, but have significant issues with fatigue or cognition, and their EDSS score might not look that bad. That's an example of why this is not considered to be anywhere near a perfect measure of somebody's MS or disease. However, we use this scale to provide lots of information and also track stability of disease over time. The EDSS score ranges from 0 to 10, where 0 is no disability or symptoms and 10 is death. So each number that you progress makes a very large difference. This scale moves in half integers, so 1.5, 2, 2.5, 3, etc. And you can see the pictograms here that are indicating somebody with an EDSS of 6 will use some sort of ambulatory aid to walk, such as a cane. Somebody who's in a wheelchair will be at a 7 or 7.5. So each number makes a significant difference in somebody's level of function. This final slide has something called the MSSS, or Multiple Sclerosis Severity Score. What this is mapping or graphing somebody's EDSS score over the number of years that they have lived with MS. So as you can see, across the top is the EDSS score, which ranges from 0 to 10. And along the side, you can see the number of years somebody's lived with MS. As we discussed on the EDSS slide, having an EDSS of 2.5 isn't necessarily going to leave somebody with that different of a quality of life as opposed to before they had multiple sclerosis. However, if you look at this chart, somebody with an EDSS of 2.5 1 year into disease is in the 8th decile of severity. And the way that this MSSS is used is that somebody tends to stay within their decile of severity over time, at least when they are untreated with disease-modifying therapy. Hence, that same individual who may not have been doing so poorly 1 year into diagnosis, if they remain on that same trajectory, could end up with an EDSS of 6 8 years later. This is one of the strongest benefits of disease-modifying therapies, and especially the highly effective ones, is keeping people at lower EDSSs and shifting them from one decile of the MSSS to a lesser decile and helping them to have a better future of living with MS.